Welcome to this video presentation of a laparoscopic left adrenalectomy. A 17-year-old patient presented with headaches, nausea and profuse sweating at the pediatric outpatient clinic, and the patient had to be hospitalized due to a hypertensive crisis. At such a young age, we suspected a secondary cause for hypertension. Abdominal sonography and MRI showed a 6 x 6 x 6 centimeter inhomogeneous tumor of the left adrenal gland. Blood tests substantiated the suspected diagnosis of a pheochromocytoma, and the decision to perform a left laparoscopic adrenalectomy was taken. The patient was positioned in a right lateral decubitus. The video trocar was placed in position 3. Trocars 2 and 4 were placed in the left upper quadrant for the grasper and just below the 11th rib for the vessel sealer. Trocar 1 was placed during the course of surgery for retraction of the spleen. Mobilization of the left colonic flexure is essential to gain access to the spleen. Especially in obese patients, extended mobilization of the descending colon is recommended to facilitate medial folding of the colonic flexure. Gently lifting the pancreatic tail aside, stepwise dissection of the splenorenal ligament proceeding all the way to the diaphragm led to greater mobility of the spleen. Then the before-mentioned fourth trocar was inserted for retraction of the spleen, hereby creating a soft tension on the remaining tissue covering the kidney hilum. The identification of the hilum and suprarenal vein is crucial for the further steps of preparation. To gain access to the suprarenal vein, the pancreatic tail was medialized. Especially for less experienced surgeons, the minimally invasive unique view of the close spatial relation of the pancreatic tail and spleen were of great learning effect with respect to splenectomy. Careful dissection towards the suprarenal vein allowed safe identification of the tumor. The stepwise mobilization of the suprarenal gland carrying the pheochromocytoma was performed moving cranially and dorsally toward the diaphragm, carefully avoiding the pulsating splenic artery. Before ligation, the suprarenal vein was gently dissected to avoid excessive adrenal hormone release. The suprarenal vein was clipped with a hemolock clip and several metal clips to then be sealed and separated with the vessel sealer. Even just slightly displaced clips may lead to extensive bleeding, impairing the view of the surgical field. The adrenal gland was entirely separated from the retroperitoneum. Especially in obese patients, this step can be particularly tricky due to the excessive perirenal fatty tissue. Stepwise lateral and medial mobilization followed, offering a rare view of the phrenicosplanchnic ligament. Total release of the gland was achieved. After confirming lack of bleeding, the surgery was completed. Histologic analysis of the gland showed a RET mutation which occurs in multiple endocrine neoplasia syndrome type 2 with a markedly increased risk for thyroid cancer. Despite normal sonography of the thyroid gland, a prophylactic total thyroidectomy was performed. Histologic analysis showed medullary thyroid cancer. Fortunately, the patient recovered fully.